Imagine being handed a medication that, well, practically guarantees you won't get a specific, highly destructive type of cancer.
Yeah, like an invisible shield, basically.
Exactly. It isn't experimental. It doesn't require radiation. All you have to do is apply a topical ointment.
Seems pretty straightforward.
You'd think so, right?
Yeah.
But now imagine that nearly a third of the patients who are handed this shield eventually just, stop using it.
It sounds completely irrational on the surface. I mean, why would anyone do that?
Right.
But when you look at the physical and psychological toll of chronic illness, human behavior gets very complicated very quickly.
It really does. And you probably already know how grueling the day-to-day reality of lichen sclerosus is. If you're following this space, you know about the severe, unremitting itch, the pain, the anatomical changes, the stigma.
Yeah, so we are skipping past the textbook definitions today. We have a very specific high-stakes mission for this deep dive.
We're looking directly at the shadow hanging over this diagnosis. The 3.5 to 5% lifetime risk of developing squamous cell carcinoma.
Which is a very real, very scary statistic for patients.
Absolutely. So the core question we are answering today is whether treating this condition effectively acts as an active cancer prevention strategy.
And we have an incredibly robust, fascinating stack of clinical data to parse through and answer that.
Yeah, we've got a lot of ground to cover.
We do. We are pulling from the official clinical guidelines from the British Association of Dermatologists and the British Society for the Study of Vulval Disease. We've also got the protocol for a major ongoing clinical trial called PEARLS.
Along with a landmark 2015 prospective study on cancer rates.
Right, and a massive 2024 nationwide cohort study out of Denmark that completely upends how we think about the immune system's role in this disease.
Okay, let's unpack this, starting with how the cancer actually takes root, because we often hear about vulvar squamous cell carcinoma being linked to the human papillomavirus, right? HPV.
Right, yeah, but that is an entirely different pathway. Vulvar cancer generally develops via two distinct roads.
And the HPV-dependent pathway is the one most of the general public might be familiar with, driven by a viral infection.
Exactly. But the secondary HPV-independent pathway is driven entirely by chronic inflammatory dermatosis, primarily lichen sclerosus.
So how does that start, exactly?
In this scenario, the cancer originates from a highly specific precursor lesion. Clinicians refer to it as DVIN, which stands for differentiated vulvar intraepithelial neoplasia.
So DVIN is the bridge, essentially.
Right. It's the stepping stone between the inflamed lichen sclerosus tissue and the invasive squamous cell carcinoma.
But I want to get into the cellular mechanics of that jump. Like, how does fiercely itchy, inflamed skin actually mutate into a malignancy?
What's fascinating here is the sheer molecular chaos that chronic inflammation inflicts on your tissue.
Chaos is a good word for it.
It really is. When the local immune system is constantly attacking the vulvar skin, it deploys a massive amount of reactive oxygen species.
Which are what exactly?
They're essentially free radicals. Think of them as chemical wrecking balls meant to destroy foreign bacteria or pathogens.
Okay, that makes sense.
But because this is an autoimmune-driven process, those wrecking balls are slamming into the patient's own healthy cells, creating a state of severe, unrelenting oxidative stress.
Oh, wow. So it's friendly fire on a microscopic
A
level?
relentless barrage of friendly fire, yeah. And over time, that oxidative stress literally steals electrons from the DNA strands inside those cells.
Which causes the mutations.
Exactly. It causes structural breaks.
Hmm.
Now, normally your cells have an inspector that catches this damage, a crucial tumor-suppressing gene known as the p53 gene.
Oh, I've heard of that.
Yeah, its nickname in biology is the guardian of the genome.
Because it inspects the DNA before the cell divides, right? It acts like a checkpoint.
Precisely. If p53 sees that the DNA has been wrecked by oxidative stress, it halts cell division.
Like putting up a stop sign.
Right. It either forces the cell to repair the DNA, or if the damage is too severe, it triggers apoptosis.
Which is programmed cell death, right?
Yeah, it forces the damaged cell to self-destruct so it can't become a tumor. But under the constant years-long siege of lichen sclerosus inflammation, the p53 gene itself mutates and downregulates.
Oh, no. So the guardian falls asleep on the job.
The guardian is totally knocked out.
Which means the brakes completely fail.
The brakes fail, the checkpoint is abandoned, and abnormal cells, those DVM precursor cells we talked about, are allowed to multiply unchecked.
Oh, that's terrifying.
It is. They eventually break through the basement membrane of the skin architecture, and that is when you have invasive squamous cell carcinoma.
So think of the local immune system in an LS patient, like an overzealous, panicked security detail at a crowded concert.
I like that analogy.
Yeah, they are causing so much chaos and physical damage trying to fight off imaginary threats in the crowd that they completely miss the actual thieves, the cancer cells, sneaking right in through the back door.
Perfectly said.
The security detail is so distracted by their own noise that the real danger just bypasses them entirely, which leads to the obvious therapeutic question. If the inflammation is the distraction causing the cellular mutation, does stopping the inflammation stop the cancer?
The clinical data gives us a resounding, unequivocal yes.
Wow.
And that takes us directly into the first line, gold standard treatment globally. Ultra-potent topical corticosteroids, specifically a class 1 steroid like clobetasol propionate.
Right, the ointment we mentioned at the start.
Exactly. These don't just soothe the itch, they bind to intracellular receptors and actively alter gene transcription to completely shut down that local inflammatory cascade.
And we actually have the data to back this up in a major way. There was a massive 5-year prospective study published back in 2015 that tracked just over 500 women with vulvar lichen sclerosus.
Yeah, it is a foundational piece of literature in this field.
And the results they found were almost unbelievably black and white, based purely on what the patients decided to do at home.
They really were. They followed these 507 women for nearly 5 years. Out of that group, 70.4% consistently adhered to their prescribed clobetasol regimen.
So they maintained that chemical shield over their skin.
They did. And in that highly compliant group, over the entire half-decade observation period, there were exactly 0 cases of vulvar cancer.
0. I mean, in an oncology context, seeing a flat 0 in a high-risk cohort is staggering.
It's unheard of, almost.
But then you look at the other side of the data set. The remaining 29.6% of women in the study were non-compliant.
Right. They used the medication sporadically or they abandoned it altogether.
And every single one of the 7 cases of squamous cell carcinoma that developed during the study occurred in that specific non-compliant group.
It's a 100% correlation within that cohort. The women who maintained the ultra-potent steroid barrier didn't get cancer. The women who left the tissue exposed to chronic inflammation did.
It's just so clear.
It clearly establishes that the steroid is interrupting the oxidative stress, protecting those p53 genes, and cutting off the DVN pathway.
Okay, but something doesn't add up here. If you're telling me this cream basically drops a high cancer risk down to 0.
Right, the non-compliance rate.
Yeah. Why are 30% of women ignoring it? Who walks away from a literal cancer shield?
It highlights a massive gap in how we counsel patients on chronic care. What we are dealing with here is a phenomenon known clinically as steroid phobia.
Okay, I can see how that happens.
Lichen sclerosus is a lifelong condition, right? There is no cure, only management. When a patient first presents with a severe flare-up, they apply the clobetasol, and usually the intense itching and burning subside relatively quickly.
So the immediate crisis is resolved.
Exactly. The crisis is over, and once the crisis is over, they look at the warning label on the tube.
Oh, right, the leaflets.
Yeah, they read the leaflets, which are often generalized warnings for conditions like eczema. The warnings clearly state that long-term use of topical steroids causes skin atrophy, meaning thinning, fragility, and tearing.
Which sounds awful.
For a patient who is already dealing with a sensitive, painful anogenital condition, the idea of chemically thinning that skin is terrifying.
Right, so the moment the itch stops, they taper off or stop applying the ointment entirely to, protect their tissue.
Exactly. But they are operating on a fundamental misunderstanding of the tissue they are treating. Healthy skin thins under steroids because the steroid suppresses collagen synthesis.
But lichen sclerosus skin isn't healthy skin.
No, it's not. It is hyperkeratotic, meaning it's abnormally thickened, and it's fibrotic, meaning it's heavily scarred.
That is such a critical distinction. What the British Association of Dermatologists guidelines stress is that active, smoldering lichen sclerosus causes infinitely more anatomical destruction, scarring, and architectural loss than properly applied topical steroids ever could.
Exactly. The steroid actually normalizes the tissue in an LS patient. It prevents the scarring.
So treating this isn't just about putting out a fire when you feel an itch. It is about proactive chemical maintenance.
You are maintaining the structural integrity of the skin. But because that steroid phobia is so pervasive, patients are constantly asking their doctors for second-line nonsteroidal alternatives.
Here's where it gets really interesting. Because the most common alternatives come with their own heavy, highly stressful baggage.
They certainly do.
I'm talking about topical calcineurin inhibitors, or TCIs. Things like tacrolimus and pimecrolimus.
Right. TCIs operate on a completely different mechanical axis than steroids. While steroids alter gene transcription to broadly dampen inflammation, TCIs are hyperspecific immunosuppressants.
Okay, so how do they work?
Well, calcineurin is an enzyme inside your T cells that acts essentially as a communication satellite. When activated, it tells the T cell to release inflammatory cytokines.
The attack signals.
Exactly. TCIs physically block that enzyme. They cut the radio wires, preventing the immune cell from calling in reinforcements.
On paper, for a patient terrified of steroid-induced skin thinning, cutting the radio wires with a TCI sounds like the perfect alternative.
It does.
But there is a terrifying paradox here. The FDA has a literal black box warning on these TCI medications due to concerns about an elevated risk for malignancy.
Which is wild to think about.
So you have a patient trying to avoid squamous cell carcinoma, and they are switching to a medication that carries a massive warning label for cancer.
The anxiety that creates in a clinical setting is immense.
I bet.
The early theoretical fears that prompted that black box warning were based on the idea that if you deeply suppress the local immune system, you might inadvertently turn off the surveillance system that keeps dormant HPV viruses or early rogue cells in check.
Basically taking the security guards entirely out of the equation rather than just calming them down.
Right. But we have to look at how the data has matured. Recent systematic reviews, including the comprehensive 2021 European Guideline Review on Vulval Conditions, have parsed decades of patient outcomes.
And what do they find?
The consensus now shows that short-term, intermittent use of TCIs does not appear to significantly increase the risk of squamous cell carcinoma in these patients. The black box warning in the context of controlled topical use appears overstated.
That's a huge reassurance for short-term symptom management. But even with that fear mitigated, the guidelines unequivocally state that ultra-potent steroids remain the heavyweight champion for LS.
They do.
If TCIs are safe short-term, why do steroids still win the long game?
It comes down to depth and efficacy. Steroids penetrate deeper and outperform TCIs in halting the deep tissue architectural changes.
Ah, so it's a deeper fix.
Yeah. TCIs might silence the surface-level T cells to stop the itch, but clobetasol gets down into the deeper layers of the dermis, completely shutting down the cellular chaos that drives the D-to-HAN pathway.
And to really understand how aggressive that cellular chaos is, we have to look at what happens in a worst-case scenario.
Which is heart-wrenching but necessary to talk about.
Right. Say a patient unfortunately does develop an LS-associated vulvar cancer. The surgeon goes in, performs an excision, removes the entire tumor, and gets perfectly clear margins.
The cancer is physically gone.
The danger should be over. Right.
You would think so, but the epidemiological reality is incredibly harsh. The studies in our stack highlight a chilling metric.
Yeah, this part blew my mind.
If the residual lichen sclerosus skin surrounding that surgical site isn't treated aggressively with high-dose corticosteroids post-operation, the patient faces an incredibly high risk of developing a brand new de novo cancer in that exact same area.
In one of the studies we looked at, the recurrence rate for new malignancies was up to 47%. Almost half the patients grew a new cancer.
Because the surrounding tissue is still suffering from that relentless autoimmune attack.
Think of the tissue surrounding the surgical site, like a smoldering ember in a dry forest. The surgeon came in and removed the active roaring fire, the tumor itself.
Right.
But the ground around it is still radiating intense heat. The oxidative stress is still happening. If you don't aggressively douse that entire area with water, meaning the topical steroid, that smoldering ember is just going to catch the surrounding tissue on fire all over again.
Exactly. The surgery removes the immediate threat, but the steroid is the only thing that neutralizes the environment.
Which perfectly illustrates why systemic maintenance is non-negotiable.
It really is.
Okay, so we've firmly established that locally, on the vulvar skin, the immune system of an LS patient is destructive, misguided, and directly creates a localized cancer risk.
Yes.
But we need to zoom out. We need to shift our perspective from the local tissue to the entire body, because this is where the source material throws us a curveball that feels almost like science fiction.
It is a total paradigm shift in how we view autoimmune disease. We are looking at a landmark 2024 nationwide cohort study from Denmark.
And the methodology here is just an epidemiological masterclass.
It really is. Using national health registries, they tracked 16,921 women who had biopsy-verified vulvar lichen sclerosus, and they tracked them from 1978 all the way to 2019.
Over 40 years of continuous data.
Yes.
The scale of that is incredible. And the twist here is genuinely shocking. We just spent 20 minutes detailing how LS aggressively increases your risk for local vulvar cancer.
Right.
But this Danish registry revealed that these exact same 16,000 women had a significantly decreased risk of developing several non-vulvar cancers compared to the general female population.
The statistics are undeniable. Across that 40-year span, the women with LS had a 50% lower rate of developing HPV-related cancers globally in the body. That includes cervical, vaginal, and anal cancers.
That's a massive drop.
Beyond that, they exhibited significantly lower rates of smoking-associated cancers, like lung and liver cancer, as well as a marked decrease in thyroid cancer.
Oh, so their immune system is doing a terrible job locally, but an amazing job globally. Is it possible their immune system is so hypervigilant and turned on by the LS that it's acting like an elite global security network, hunting down HPV and other rogue cancer cells everywhere else in the body?
If we connect this to the bigger picture, that is the exact biological hypothesis this data demands we explore.
It's just wild to think about.
The precise molecular mechanisms remain elusive. This is cutting-edge epidemiological tracking that now requires aggressive cellular research to decode. But it strongly suggests that lichen sclerosus isn't just a localized dermatological glitch.
Right.
It represents a highly complex systemic immune posture.
It's like their baseline immune system is operating at a constant state of high alert.
Yes. That state of high alert is catastrophic for the local mucosal tissues of the anogenital region. But systemically, that same hypervigilance seems to act as an aggressive shield against external oncogenic triggers.
Whether that trigger is a virus like HPV or the cellular DNA damage caused by inhaling cigarette smoke.
Exactly. The immune system is hunting down those specific threats with a heightened efficiency that the general population simply doesn't have.
So what does this all mean? How does modern medicine manage an immune system that is simultaneously trying to protect you globally from lung cancer while actively trying to harm you locally on the skin?
That specific tension brings us right to the frontier of modern clinical care and a major ongoing randomized controlled trial based in the UK called the PEARLS trial.
Right, PEARLS. It stands for Proactive Against Reactive Therapy for Lichen Sclerosus.
Exactly. Because even though we know from the 2015 study that steroids prevent cancer, there is still a fierce debate over the long-term protocol for applying them.
Doctors are still arguing over how much is too much.
Precisely. We know clobidasol works, but we lack the gold standard randomized controlled trial data to prove the absolute optimal dosing schedule to balance safety with total disease suppression.
Which is where PEARLS comes in.
The PEARLS trial is designed to settle this clinical dilemma by dividing patients into two distinct long-term treatment arms. The first arm is investigating reactive therapy. This is highly symptom-driven.
Which is how most of us naturally interact with medicine. You get a headache, you take an ibuprofen, the symptom dictates the response.
Exactly. In the reactive arm, the patient only applies the ultra-potent steroid cream when they experience a clinical flare-up. When the physical itching, tearing, and pain return. They treat the fire, put it out, and stop.
But the second arm of the trial is evaluating proactive therapy.
Right. And this is the maintenance approach. In the proactive group, patients apply the steroid cream on a strict schedule, typically twice a week, every single week, indefinitely, even when they feel absolutely perfectly fine.
Even when there is zero itch and zero pain.
Yes. The goal is to keep the cellular environment chemically suppressed, so the oxidative stress never has a chance to build up in the first place.
We already know steroids stop the DVIN pathway. What PEARLS is going to give us is the definitive proof of whether a strict, symptom-free maintenance regimen prevents the physical scarring, the loss of architecture, and the microscopic disease progression significantly better than just chasing the flare-ups.
It is the clinical difference between running emergency damage control and performing structural preventative maintenance.
That makes total sense.
The hope in the dermatological community is that the PEARLS trial will yield the undeniable, rigorous evidence needed to standardize proactive care guidelines globally.
We want to give patients a clear, evidence-based roadmap that removes the anxiety of that steroid phobia by proving exactly what regimen secures a symptom-free, cancer-free life.
It really forces you to reframe how you look at that little tube of ointment on the nightstand.
Totally. If you are a patient navigating this, treating lichen sclerosus isn't just about relieving an annoying itch so you can sleep through the night. It is an active, highly effective, scientifically proven mechanism of cancer prevention.
That is the single most vital takeaway from all of this data. Strict adherence to a treatment plan, specifically utilizing those ultra-potent topical steroids, directly short-circuits the chronic inflammation.
Powerful stuff.
It halts the oxidative stress, it protects the structural integrity of your p53 genes, and it entirely cuts off the biological pathway that allows squamous cell carcinoma to take root.
It's an incredibly empowering shift in perspective.
Right.
You aren't just passively managing a chronic painful illness, you have agency. You are actively, daily, shielding yourself from malignancy.
You hold the shield in your hands.
Yeah.
But looking beyond the immediate treatment protocols, this raises an important question, and one that brings us right back to the mysteries uncovered by the Danish cohort study.
Okay, listen.
If the hypervigilant immune environment of a patient with lichen sclerosus inherently protects them from HPV-related cervical cancers and smoking-related lung cancers, what secrets does this condition hold for the entire future of global cancer research?
Wow, that is profound.
If molecular biologists can decode the exact cellular mechanisms of lichen sclerosus, if we can figure out exactly how these hyperactive T cells are so effectively hunting down rogue mutated lung or liver cells, could immunologists reverse engineer that mechanism?
Oh, man.
Could the very autoimmune disease causing so much intense local suffering hold the biological blueprint for a new systemic vaccine or therapy to prevent cervical or lung cancer in the general population?
It's a staggering thought to leave on. The idea that a condition so deeply stigmatized, so frustrating, and historically so misunderstood might eventually be the skeleton key to one of the biggest medical breakthroughs in oncology.
It's entirely possible.
Thank you for joining us on this deep dive. Stay curious, keep pushing for the why behind the medical advice you're given, and remember, even when the diagnostic landscape feels incredibly murky, the science is always working quietly in the background to bring the bigger picture into focus. See you next time.